Everybody, thank you for having me. Let me first say my disclaimer. This is just a speech. It may bring on emotions. It may bring on sadness and joy. At the end of it, it should give some hope. So persons present for care in non-acute settings for any number of reasons. But one underlying theme which lies in the background of many presentations is the presence of the chronic non-communicable diseases, diabetes, hypertension, high cholesterol, and obesity. 10 to 15% or 10 to 20% of Caribbean people are diabetic. 10 to 20% of Caribbean people are pre-diabetic. 20 to 40% of Caribbean people are hypertensive. 30% of Caribbean people have high cholesterol. And 30 to 50% of Caribbean adults are overweight or obese. In diabetes, a person's own insulin becomes ineffective, as the purpose of the body's insulin is to remove sugar from the bloodstream to put it into the cells of the body for use in metabolism. In diabetes, failure of your body to produce adequate insulin or failure of your insulin to work results in sugar accumulating in the bloodstream, and the presence of this sugar in the blood damages blood vessels all over the body. High cholesterol, particularly in the presence of diabetes, results in the deposition of cholesterol plaques in the arteries of the body, worsening the damage. Progressively damaged blood vessels then, over time, reduce blood flow to the lower limbs, causing what is called peripheral vascular disease. Eventually, inadequate circulation of blood to the legs contributes to what becomes, for all intents and purposes, gangrene, leading to the need for amputation. Damage to blood vessels affecting blood flow, when it happens to the blood vessels of the brain, causes stroke. Damage to the coronary arteries causes heart attacks. Hypertension and high blood pressure put an additional strain on the blood vessels, causing further damage. High blood pressure also strains the heart, resulting in enlargement of the heart, which makes it weaker, causes heart failure, damages the valves to cause valvular heart disease, or damages the electricals, causing arrhythmias, which can increase your risk of sudden death or stroke. Obesity also strains the heart, resulting in enlargement of the heart, and through causing poor metabolism, worsens diabetes, worsens hypertension, and worsens high cholesterol. The chronic non-communicable diseases are caused by the adoption of a Western lifestyle, no exercise, refined carbohydrate overload, overindulgence in greasy meat dishes, and unfortunately, the complications of these conditions are, as just described, heart attacks, heart failure, strokes, circulatory problems leading to amputation, and kidney failure. Stroke is the leading cause of death and adult onset disability in the Caribbean. The cardiovascular diseases in general are a major public health concern, with heart attacks being the other major cause of cardiovascular death. Rising amputation rates due to damage to the lower limb blood vessels has left many disabled. Diabetes and hypertension are the leading cause of end-stage kidney disease in the Caribbean. And in the region, dialysis units are already extremely full of these patients. To add to the disease burden, the Western lifestyle also contributes to a rise in the incidence and prevalence of cancers, on top of a background of what appears to be strong genetic influence. So obviously, there is a huge role for prevention here, with health promotion programs encouraging the adoption of a healthy lifestyle, plenty of exercise, reducing refined carbs, reducing animal fats, and increasing fruit and veg. However, it is also obvious that the role of clinicians in primary care is huge. Beyond prescribing, looking at weights, blood pressures, blood sugars, and cholesterols, primary care clinicians must also actively look for the complications of these conditions so that they can be addressed early, and must also actively look for cancers. Significant obstacles in healthcare delivery have been our failure to diagnose peripheral vascular disease early, resulting in too many amputations, our failure to effectively manage heart attacks, our failure to diagnose and manage stroke patients effectively according to international standards, our failure to provide dialysis to patients in end-stage kidney disease, and our failure to diagnose cancers early. After identifying the problems, the solutions are obvious and the way forward is clear. Number one, in terms of peripheral vascular disease and amputations, in the district clinics and in other primary settings, clinicians must pay great attention to foot assessment in the high-risk patient population at every patient encounter. We want to ensure that we're assessing the circulation of these patients with vascular Doppler ultrasound and early referral to a vascular team, both being solutions. So vascular ultrasound looks at the flow of the blood through blood vessels, which can detect peripheral vascular disease fairly early on, and the vascular surgeon who could visit or be available electronically can liaise with clinicians in the districts to make decisions on the timing of intervention for patients so that they don't have to result in amputation when they have these conditions. Stroke patients requiring CT for a diagnosis, finally this year, after our 15-year-long ask, have access to local CT scanning. But what happens before and after CT must mirror first world countries in terms of speed, efficiency, and accuracy in healthcare delivery. The team must have the involvement of an electronically present off-island stroke team. Very important decisions have to be made by a stroke specialist, the medication administered, the need for medevac for an intervention when necessary, for example, for thrombectomy. So for many strokes, you do medical management where you administer medication. Now there is clot busting medication that you can give in an acute stroke immediately after the scan diagnosis, but this has to be done in liaison with a stroke consultant, so we're trying to get that connection. Some patients who've had a stroke can benefit from thrombectomy, that is mechanically removing the clot from the blood vessel, and the outcome is completely different. So in the Montserrat setting, traditionally, I should say, because of our lack of CT, somebody has a stroke, they go down on the ward, they're waiting for the scan, the 4-hour window long passes, days pass, we don't have a CT diagnosis, therefore we cannot start the intervention necessary, and we have thus left the person with permanent paralysis or inability to speak. In a first world country, because of thrombolysis for acute stroke or thrombectomy, with that intervention, the following day, that same patient can be sitting up, having a cup of tea, reading a newspaper, and I've seen it happen. Number 3, certain patients who have a heart attack may require immediate medical evacuation to a coronary care unit where the blocked artery can be unblocked, allowing the patient to live. But this has to be done quickly with transfer within an hour or two, not within 1 or 2 days. On medical evacuation, the speed of medical evacuation is extremely important. As it relates to all patients warranting medevac, we have envisioned a helipad at Glendon and a fast escape for some patients whose survival depends on urgent medical evacuation to a tertiary facility without any delays. So this will be some strokes, some heart attacks, and some major trauma patients requiring an intervention. By having local CT scanning, which we have finally achieved, we are saving money that we can spend on a more selective medevac process after diagnosis. So we diagnose locally, we discuss, we send. In kidney disease, in 1 week's time, we shall have a budget for how much we need in order to get a 2-bedded dialysis unit going with a target of 1 year. So we have promised during our election campaign as a United Alliance that we are keeping our target for achieving dialysis as 1 year from now. Dialysis is available in all sorts of fairly destitute countries. The Bridge of Life that Nurse Daly and her Helping Hands of Glendon facilitated in coming to Montserrat has done an assessment and will be working on a budget for how much we need. This company, Bridge of Life, is one of the non-profit branches of the non-profit arm of DaVita, DaVita is one of the biggest dialysis providers worldwide. Their for-profit arm provides dialysis to rich countries and they make a lot of money. Their not-for-profit side reaches out to poor third world countries, and presently in countries way more destitute than ours, people are managing to stay alive because of dialysis. So this is something that is not beyond our reach. So there's no reason why we should see dialysis as something beyond our capability or beyond our pocket. With end-stage kidney disease on Montserrat, our only options which we have traditionally given patients is migrate or die. And these cannot be the only two options that we offer. Finally, under healthcare, finding cancer early. In order to survive cancer, early diagnosis is essential. We envision an electronic cancer screening registry and in a form of electronic medical record, which can log patients for cancer screening, keep track of results and referrals, remind us of individual appointments for screening. To do so, we are in the process of enlisting some of Montserrat's brilliant digital minds, and we will partner with existing cancer screening charities. On island, we have definitely failed to diagnose gastrointestinal cancers early, but help is on the way through a visiting team, which will help us to get through our list of persons requiring cancer screening, so requiring upper gastrointestinal endoscopy and colonoscopy, so that our stomach cancers and our cancers of the colon and rectum can be diagnosed early. We are failing in prostate cancer because our men are not coming forward for screening, despite obvious attempts at cancer screening every year by various charitable organizations and by the Health Promotion Unit. Thankfully, at the present time, prostate biopsies have been available on Montserrat for at least a year, both through a government and a private route, and presently routes for the treatment of patients with cancer of the prostate are being sorted out. But men need to come forward. Prostate cancer, as I hope everybody in the room by now knows, prostate cancer affects 1 in 4 Black men compared to 1 in 10 men in a normal population. Dying of prostate cancer that has spread to the bones of the body is an awful, awful way to die. Early detection. Other aspects of healthcare delivery that will also help. We are hiring an emergency medicine consultant who will adopt guidelines and protocols for the emergency room, who will train staff, who will transform the casualty department into an emergency room. Additionally, we're preparing for 24-hour doctor cover in the emergency room by hiring additional doctors. Additionally, adjusting health law and health policy remain on our list. The legislative framework on which what we do in health rests is too old and too outdated to be considered protecting the populace. Knowing about the problems in health for years and having plans in my mind and being involved at different levels over time has, made it easy for me to brace myself in coming into the role. But education, I was pretty shocked at some discoveries. Education presents itself as a minefield of despair. With the struggle of our children to be adequately supported, guided, and taught throughout primary and secondary education, and then presenting to us as poor performance, non-performers, and behavioral problems. We blame the children when we did not, as a nation, provide a fighting chance for so many of them. Many students simply needed more educational support, more than what the present service and present staffing levels and present and past budgets could provide. Some students managed to perform and achieve, thankfully, through hard work and dedication, yes, but also for some through sheer genius, through family support, or through the luck of being taught by the right combination of caring and inspiring teachers and the right presentations of opportunity. At the same time, in this fairly deprived ministry, I have discovered in our teachers an oasis of hope, goodness, an oasis of dedication, of loyalty, and of commitment. A devoted teaching population who, despite all, have remained with us here on Montserrat and have remained in the profession. Despite the desperate need in education, somehow we are always down on manpower when it comes to teaching. Staff report delays in having repairs done and in receiving supplies. The budget simply has not provided enough. Our teachers are asking for teaching assistants to support them with teaching, with control of the classroom, and with students with additional educational needs. They're asking for supplies for their classrooms and to have repairs done. There are no extreme tasks in the teachers' asks. With the cost of living as it is on Montserrat, and with other islands offering better remuneration packages, we must urgently address teachers' needs or they will leave. This government intends to review what we pay our teachers in comparison to the other islands. We intend to allow teachers to be in the same non-fee paying category as health workers, fire, police. We intend to find housing solutions for them, and we intend to further assist in their continued professional development and find, obviously, quick pathways for them to access supplies for the classroom. No longer will teachers, despite their own financial hardship, have to buy supplies for the class out of their own pockets. Basically, they're teachers who cannot get the things that they need, and they are buying the things that they need out of their pockets just to make sure that they have what they need to teach the children. I know one teacher waiting on supplies since 2017. There's a story of chemistry supplies waiting for the last 3 years. There are enough stories to break my already sad little heart. As we speak, our new PS of Education, an extremely capable and competent woman, is busy allocating money for repairs and for supplies. New in education, we are abolishing the leveling test, which over a 15-year period, has inflicted on students in the last year of primary school and in the first 3 years of secondary school what seems to be sheer horror. A test intended to stream students, but only seems to stream students downwards, despite improvements in performance noted by teachers and parents. The test demotivates and demoralizes students. It is a test which is no longer even used in the schools in which it originated, and it is a test for which there is no syllabus and there is no teaching. A new curriculum is to be implemented. The assistance of a regional organization was sought in 2021, which assisted with the writing of a new curriculum for early childhood education, primary school, and MSS forms 1 to 3. This has not yet been implemented, I'm assuming delays due to COVID, etc. We expect to pilot this in January, and we expect it to be fully implemented by early next year. We have a new commitment to increase the focus on vocational subjects in educational programs, as educational programs, and these will provide skill-based learning and a focus on how to teach students practical skills. We will increase the focus from primary through to secondary school and on to the Montserrat Community College, where we hope to soon see a vocational side mirroring the successes of the academic side, and the vocational side will also include nursing education and teacher training. The need for support in vocational studies brings me to what in the past has been the elephant in the room in education, which is the reality that many students require educational assessments and additional educational support in order to make it through a system that has for generations assumed that all students have identical learning abilities and that all students learn the same way and need the exact same level of support. So this is special educational needs. And just to explain, yes, there are children with profound physical and mental disabilities that exist. There are also students who do not have obvious physical and mental disabilities but struggle academically, who have been missed through the system. And there are students who appear almost normal and who manage through their hard work to achieve something academically, but require an assessment, need additional educational support, and would go further if we manage to support them in that way. The lack of educational assessments and the lack of educational support has left a large proportion of an entire generation unable to optimize their needs in our school systems. Their non-performance makes them feel bad. Their failure to perform in the eyes of a service that has not understood how to support them makes them feel bad. Often behavioral problems and even more inattention result, as losing the battle most of the time is not a confidence booster and does not help. We must empower the students themselves and their teachers and their parents. In our oasis of teachers that I spoke of, there are a group of special educational teachers who, without the dedicated training that they need and without the training that they have asked for, have become self-taught SEND teachers, finding interesting ways of engaging students through handmade games and devices. These teachers deserve our praise for their commitment and their dedication to further learning, and we're hoping to be able to offer it to them, to offer advancement to them. So some SEND solutions, or special educational needs and disability solutions, are: number one, we are attempting to urgently fill the role of education psychologist presently vacant, and we expect to support the post holder with the staffing required to create a framework for special educational needs and disability students that we can build on. We must have our students assessed for special educational needs. We must support them with individual plans. Many with minor needs are often overlooked, as we said, and educational support can be the difference between 3 O levels versus 7 O levels. These children just need additional support. We have made a new spend request for a speech and language therapist to support our SEND students and the SEND team, who will provide interventions, and particularly early interventions to students. Presently, there are lots of students in the early childhood age group who have been diagnosed with special educational needs, who have delays, some developmental delays involving being able to speak. And it's really important that the interventions happen early in order for us to make a difference. We plan to train parents, teachers, and teaching assistants in teaching students with special educational needs. Our parents, our teachers, and other persons in the community are asking to be trained. So our population is very willing to help. We expect to commit to providing the materials, the environment, and the staffing ratios needed for teaching students with different needs. And we plan through focus to prepare most of our SEND students to be ready for the working world at some point, as opposed to becoming dependent on the state. The Education Act will need some adjustments when it comes to special educational needs. In the Education Act, Part 4 under Special Education, 80 number 1 says that the Director of Education shall, subject to availability of resources, provide educational programs for students with special educational needs. So it should not say subject to available resources, because one could argue that there are never any resources, but resources need to be found. It also speaks of a special educational program may take the form of an individual educational plan, and the plan is tailored to the specific needs of the student. So it cannot say may take the form, it must say should take the form. So the Education Act does support the teachers and students with special educational needs, but just needs some adjustment to make sure that we are compelled to do what we need to do, and therefore we shall write policies that will support what we do in special educational needs. In summary, there is hope. And I urge that we do not give up on ourselves on this island. And I know that we will continue to find solutions to our problems as they arise in both health and education.